All right, everyone, good day and welcome to the CVMA's second edition of the Town Hall for Navigating Through COVID-19. My name is Melanie Hicks and I'm the president of the CVMA as well as the moderator for these sessions. I would like to take a moment to thank Hills Pet Nutrition for generously sponsoring this Town Hall series. I'm joined by our host, Dr. Scott Weiss, who is a professor at the Ontario Veterinary College, and he's the director of the University of Guelph Centre for Public Health and Zoonoses and chief of infection control at the Ontario Veterinary College Teaching Hospital. Before I hand it over to Dr. Weiss, I wanted to ensure that everyone knows that this session is being recorded. We've also muted all participants to ensure the best audio experience for everybody. I would encourage you to keep your chat box open. We would love to have any feedback and comments and questions, and Dr. Weiss will be addressing that along the way. I will be monitoring the chat box on a regular basis, so please feel free to type in any comments and questions there, but make sure that you do send it to everyone, and that way everyone can see the questions and comments. And with that, I will hand it over to Dr. Weiss.
Great, thank you. I'll just get my slides up here. So thanks for coming back, those of you who were here last time. So if you weren't here last time, this is really supposed to be as much interactive as interactive as we can make it, as much question and answer based as we can. So what my plan for today was to go over a few different developments. There's not really been a whole lot in terms of the disease standpoint, but go over some developments on the animal side, some background on the human side that's relevant to our progression through to the next stage, which is hopefully a recovery stage, and what we need to be thinking about in veterinary medicine. As before, if you have any questions, feel free to email me. If it's an urgent thing, put urgent in the title, and don't be afraid to chase me if I don't reply quickly. I try to get back to vets, within hours or the day, and if it's urgent, as quick as possible. So don't be afraid to track me now. Okay, so like I said, I want to give a quick update on what we've learned over the last week or so with SARS-CoV-2 in animals. Not a lot. Talk mainly about social distancing during the recovery phase, and we'll pause for questions and answers as much as we can. So please put your questions as we go through and we'll focus on that. Before I get to the animal side, I just want to talk really briefly about the human side, because that relates to where I'm going kind of next, which is the recovery phase and what we are going to need to do and why, right? It's important to understand why we're going to have restrictions for quite a long period of time. So if we look at data from Canada, this is, I grabbed it yesterday. It looks like it's updated as of the 4th, 61,000 reported cases overall in the country. Now that's an underestimate, as we know, not everyone that's sick gets tested, but we need to put numbers into perspective. And we need to think about this as it relates to the question that comes up for me a lot is, okay, are we reaching herd immunity, right? Are we getting to the point where we've got enough people that are infected and enough people that are immune that we can back off, right? Vaccine would be great, but are we there with the herd immunity? And the answer is not anywhere near it. So if we look at here, the population of Canada is in the 37 million range. 60,000 is a small chunk of that. If we say it's a 10 times underdiagnosis or even 100 times underdiagnosis, if we have 100 infected people for every diagnosed person, and this is a big and, every one of those has, significant protective, long-lasting immunity, we still have the vast majority of the population that's susceptible. We don't know what level we need for herd immunity, what population protection we need to really limit transmission of this. It's presumably not 97% like measles, but the 2/3 to 70% gets tossed around a lot. So if we need to get up into kind of this area to have reasonable herd immunity to slow down transmission, we've got a long way to go. And the way we get there is disease or vaccination, right? And if we get there by disease, that's a lot of people, and we're going to lose a lot of people in the process. So this comes back to why we aren't just going to hit the switch and say, okay, well, we've controlled it and we're back to business as usual. No, because this is a widespread virus. It's still a predominantly susceptible population with a huge number of people that are at significant risk of complications. So that's why we're going to see this requirement to consider distancing. And this is, I think, an important statement to think about. Opening up doesn't mean the outbreak's winding down. It means there's room for you in ICU. It means if you need a vent, you can probably get one right now. And that's why things are opening up. And that's not always going to be the case, because we're anticipating kind of rolling surveillance or rolling closures. As things get loosened up, case numbers will go up. And what we're going to have to see, presumably in some areas, is reintroduction of restrictions. So for us, that's relevant in terms of long-term planning, right? We're not focused on social distancing steps and modifying our practices as something we just need to do for another week or so. We need to be thinking about these in the long term, and we need to think about how we can ramp these up as needed. So there are a couple of aspects here I think is important. One is just the recognition that this is a new normal for a while, months at least, that we're going to have to do some of these things. The other thing is there are a few reasons it's very important for us to do this. One is just social responsibility, right? People are dying, and we need to limit that through, not contributing to transmission through vet clinics. The other thing that I think is really important from a kind of a broader business standpoint is we need to be able to say that we're good, right? So in Ontario, for example, we've got this urgent care directive that we hope will be lifted very soon. Now, as things get loosened up, more restrictions will come back in if case numbers go up. And I think what we need to be able to say as a profession is we're good, right? We've got these practices, we're doing them, we're sustaining them, we've got really good compliance. So if we get to a situation where restrictions are being rolled back in, we're still saying we're essential services and open for normal types of services because we were doing this really well. So this is just, it's a bit of a soapbox issue for me, but it was, we put up with some pretty significant pain by eliminating our activities. We want to make sure those are beneficial for us in the long run by not having to go back to them. So that's going to lead into the second part of the talk, or the main part of the talk, which is talking about how we do this. And that's where I think hopefully we'll get a lot of discussion. So what's new with COVID-19 in the animal world? Well, not a ton over the last week, really. There was that, if you follow our Worms and Germs blog, you get reports on this quite a bit. There was an infected cat in France. This is a pretty typical story. Owned by an infected person, and the cat had mild respiratory and GI disease. We get a lot of anecdotal reports of this, and we get anecdotal reports of some cats with serious disease, including the odd death. We haven't been able to investigate many of these. My suspicion is this is like in people. The majority of cats that get infected get subclinical disease. Some will get mild disease, but there will be a subset probably that will get more severe disease. And, it's more likely going to be with an older cat or a cat with other comorbidities. But I think we need to be looking out for serious infections. My suspicion is they are occurring. We're just not seeing a lot. So I think be aware of that. We need to still be querying contact. We need to be thinking about respiratory and GI disease as potential signs of COVID, realizing that there are a lot of other things that cause it and common things that occur commonly. Our surveillance is continuing. We're looking for this virus in animals that are in contact with infected people, and we're hoping to throw a broader net in animals that are sick. So if you have concerns about cases, like I said at the start, feel free to contact me, and we'll see how we can help out with that. The cats from New York that were reported before, just follow-up information on that. They seroconverted. It's not surprising. It just provides more evidence they were truly infected. They were positive on PCR over a relatively significant period of time. So it really was a true infection. Seroconversion rounds that out. And with that story, and if you remember the story, these are two cats from New York City with mild disease. One of them was the classic situation where the owner was affected. The other one wasn't. And there was no known positive person in the household, which brings up two scenarios. One is it was an asymptomatic infection in the person and it was reflected in disease in the cat. And hopefully that's the scenario, because we want this to be a predominantly human disease where we see this sporadic spillover into animals. The other scenario that was posed was this cat was an indoor-outdoor cat, and maybe it got exposed outside. Now, your typical indoor-outdoor cat probably doesn't encounter a lot of people. It encounters maybe more cats. And the suspicion that, okay, maybe one of the options was this cat picked it up outside, which would be concerning, because that means we could have the potential of movement into feral cat populations. And that's something else we're hoping to look at. But another reason we're emphasizing to, if you have owners with COVID, we want them to socially distance their whole family. We want them to socially distance their animals as part of that, because we don't want the animals to act as a bridge. If people keep their animals with them, the animals, the cats in particular, don't pose a risk for transmission. If they bring them to us, or they let the animal outside, then they create a chance for bridging from that household. If the people are doing a really good job, but the animals are going out, we create some risk. So if you're dealing with infected people or people are calling, we really want to emphasize the importance of keeping animals contained, just like they're keeping the human components of the household contained. So can cats and ferrets get sick? I think it's fairly clear experimentally and from some field work they can get sick. Can dogs get sick? It's still unclear. you know, we get the odd report of coughing dogs in households with people with COVID. I'm not convinced enough that these aren't just run-of-the-mill canine respiratory diseases, but something that we still need to look at based on the experimental data, based on their predicted susceptibility, based with the receptor. We think it's probably unlikely dogs are getting sick, and the few dogs that have been identified with natural infections haven't been sick. So I think it's something we should be aware of and not dismiss completely, but I'm not particularly worried about a dog developing disease. Cats and ferrets are the ones that we're worried about. Still pretty limited information about other species. Natural disease in mink reported in Europe in a couple of mink farms in the Netherlands. We know hamsters can be infected experimentally. Presumably they can be in the real world too, non-human primates. It's kind of the usual suspects for this virus. No more information on livestock that I've seen. You know, there have been various experimental studies with livestock. Not many have been reported out yet, but from what's been reported, no susceptibility of pigs, which was our big concern, as well as poultry. But hopefully we're going to get more information. Just on the veterinary guidance side, this is a document prepared, the bottom explained. It's a working group of various people in public health, in animal health, CVMAs there. I'm there coming up with answering frequently asked questions for veterinarians. It's not a group that's got any kind of formal thing. That's why the disclaimer just is very vague in who wrote it. We've come up with an updated version of this. I think Logan's on the call. If she wants to make any comments about it, feel free to pipe up. This has been released, an updated version, a couple days ago. It's available on our Worms and Germs blog. It's available at various sources. I think CVMA sent it out. You can find it fairly easily. It just goes through a lot of the basic questions about animals. And there's a lot of things that we say we don't know, which is fair to say because we don't know. But we're advancing kind of the complexity of some of these answers over time as we learn more. Something else you might have seen previously, and I think I alluded to it the last one, was CDC guidance. So CDC came pretty late to the party on this, where they spent the first few months trying to say there's nothing to think about. Then they came out with guidance for management of animals that were exposed or potentially infected. They got a lot of pushback for some of their recommendations because they really didn't differentiate the likelihood of disease and, a cat with respiratory disease versus a cow with diarrhea or a neonatal calf with diarrhea. The risk of COVID is very different in those, but it wasn't really nuanced very well at the start. So they came out just a few days ago with a revised guideline. This table is fairly useful to get people thinking about when we would use different PPE. It's not absolute, and they're always varying shades of gray, but it's good guidance on when we think, okay, business is kind of the usual, when we're thinking extra levels of PPE, or when we're thinking the highest level of PPE, so an aerosol generating procedure in an animal with exposure to someone with COVID-compatible symptoms, and should be signs. But I would say cats would be my highest risk here. Would we do the same thing with dogs? Here's where the clinical judgment comes in. So you've got a dog that's been kennelled, that's got respiratory disease, and the owners are positive. Well, I'm not really concerned that dog's got COVID. Maybe it's still infected and it has it in the respiratory tract, versus a cat that's indoor, never goes outside, and has developed clinical disease after its owner's been sick. I'm very concerned about that, and really want to make sure if we have to do an aerosol generating procedure that we're using optimal protection, which in these recommendations, and which I would do as well, would be N95 mask, eye protection, face protection, and everything else. So it's a good general reference. And the various guidance come down to similar things. I've kind of got a more simplified version here. This is in a document that I'll mention in a few minutes that just went out through OVMA. Same type of thing, same general approach. It's just part of our recommendations going forward, identifying situations where we're going to use enhanced personal protective equipment. So maybe I'll pause for questions right now. I think there are only a couple there so far. I see the one about the sniffer dogs. Yeah, so a comment about study using dogs to sniff out human COVID cases. Yeah, I get a question like this from pretty much every other day. Various people have been talking about doing it. We don't know if it'll work, right? So the dogs don't smell the virus. They smell a metabolite that's produced. So if someone gets infected, they're smelling something specific for that infection. Will there be something? We don't know. There are various types of dogs are pretty remarkable in what they can smell. It's possible. Brings in a question of where would it really be useful, right? We've got lots of diagnostic testing options. The dog's quicker, but is it going to be more sensitive, specific, and better than diagnostic tests? The other thing that brings a concern, though, is if we've got COVID concerns in a facility, Do we want to bring a handle, or do we want to bring a dog in there? And if the dog's sticking its nose in places where the virus might be. So it's an interesting aspect. You might get asked in clinic about people that are doing this. We have no idea at this point. I haven't seen any evidence that it works at this point, although people are looking at it, and the cost benefit and the risks from handlers and dogs would still be a bit of a question. Are there other viruses where asymptomatic is most likely? Wondering if 100 times or 1,000 times undiagnosed cases or more does occur with other viruses. That's a good question. We don't really know. There's a lot of certain, if you look at other coronaviruses, the common cold, the coronavirus is one of the causes of the common cold. Certainly it can circulate in clinically unaffected individuals. The undiagnosis numbers aren't just dealing with asymptomatic infection, so remember that. So we've got a couple of reasons we underestimate numbers based on our diagnosis. So one of those is asymptomatic infections, and people just don't know about it and don't seek testing. The other is just lack of testing, so lack of testing infrastructure. So we're missing some that aren't affected, or sorry, that aren't clinically affected, and we're missing some that just don't get tested. So other viruses, certainly it's very common for other respiratory viruses to have people that are asymptomatically infected, and it's obviously exceedingly common for a minority of them to be tested. The 100 or 1,000, whatever number, it's a pure guess out of the air. We just know that there's a large population of people that are infected with this virus, and we don't know. And that's why everyone talks going forward, we really need more testing so we have a better understanding of what's going on. And if we're going to use contact tracing as a way to help control this, we need good testing. If you're only testing 1% of the infected population, contact tracing doesn't get you very far. Can you confirm if grooming or clipping is considered aerosolizing? Well, probably not. I think the aerosol risk in grooming or clipping would be working around the face of a dog. A panting dog for me is an aerosol generating procedure, because I think it's fairly clear that's not the normal breathing we would think about in a person or some other species. So clipping, grooming, working around the head shouldn't be aerosolizing. If they're clipping around the face and there's saliva all over the hair, clippers maybe could aerosolize, probably not truly aerosolize. They could spread droplets, I would suspect. I think that's pretty low risk, and the hand contact is probably as much of a risk as any droplet generation. More of my concern with an affected dog and aerosolization would be my face right in front of the dog's face as it's panting, because I think that the forcefulness of breathing is probably going to generate some droplets that could spread.
We have two more questions actually that came in privately. So the first is, are you accepting swabs from animals all across Canada? What's required? What kind of storage?
Yeah, so we're still working on that. So a couple of testing issues. One is overall, everyone's discouraging routine testing for a couple of reasons. One is it doesn't impact care of the animal. And the other is we just don't want animals coming to clinics that don't need to. So if people have clinically affected animals that are in the clinic, that's a different story, because we've already got the animal there. We've already got the exposure, and we're working on ways to get samples sent in from everywhere. For surveillance, so if you've got a client that's infected and there are animals in the household and they're wondering what testing the animal, we don't, I'd like to test them, but functionally we don't want to test them, because testing them is going to require someone going to that household, which is what we're doing locally, and bring some PPE requirements, or it means they have to take that animal out of the household. So taking an animal out of an infected household for a procedure that requires close contact and won't impact that animal's care isn't what we want to do. But if people are interested in exploring this, let me know. We can talk. If they get a clinical case, for sure, we've got some, and the animals in the clinic, we've got some ways to do it. There are potential other things we can do, such as getting owner collected fecal samples. Feces, we don't know how good a proxy it is. We certainly know we've seen some positives in reports from cats and lions and tigers of being fecal positive, so it may be a bit of a proxy. But at this point, the biggest issue is sample collection, because we don't want any more handling of these animals from positive households. So quick take on, if you have a clinically affected animal and it's in your clinic and you're getting samples and it's been exposed to this virus, get a hold of me and we can look what kind of testing support we can give you.
Great. And the second question was just relating to fecal swabs in animals, if they should be sending those in. So I think you addressed that question.
Yeah, so actually, I wasn't sure I was going to get to this slide. So for testing, we don't know the optimal ways to test. And that's one of the reasons we're testing multiple sites, is so we can hopefully figure that out over time. We've got an exceptionally small number of animals internationally that have been tested and that have been positive. So for our surveillance, we're doing nasal swabs. This is my probes, and these are superficial nasal swabs, because getting deep nasal swabs, is a challenge in a household in particular with an owner holding them without sedation. So, and with some of our respiratory viruses, distal nasal swabs are still quite good. Flu is a classic example where it's quite good. So we're doing distal nasal swabs, oropharyngeal swabs, and rectal swabs. Collecting feces is an option, and for owner-collected samples, feces is obviously one that we could do fairly easily. IDEXX, their recommendations are a little bit different. They say pharyngeal and conjunctival swabs in the same tube is what they recommend, plus or minus a deep nasal. Conjunctival, I think, is largely there because that's typically part of what they do for their respiratory panels. I don't think we have anything that would suggest that conjunctival swabs are higher yield for this virus. I said I'm not doing them, maybe I'm wrong. I just haven't seen anything that would suggest conjunctival swabs being high yield for this, but for the other diagnostic tests, some of the other pathogens, conjunctival swabs are higher yield. So that kind of ties into their recommendations. And for GI disease, they're recommending a fecal sample. Fecal samples are better than swabs if we can get them just based on the bulk of material that's there. All right. So keep on sending questions if you have them. What I want to head on to now is getting away from the medicine and getting more from the function and the infection control and how we move to the next phase. So like I said at the start, we're not going towards normal, we're going towards less abnormal, which is our goal. And if you think about what's happening in grocery stores and what's happening in other businesses that are open, those are some of the same concepts that we need to start thinking about. Because we've got some of the same risks, right? We bring people into our facilities or to our facilities and we create some exposure risk. So I think overall, and this is going to vary by province, and it's going to vary over time, and it might even vary within province as we see kind of restrictions being replaced. So anticipate loosening or removal of restrictions on what can be done if there are restrictions on what can be done. And Ontario is my example, where we've got this urgent care directive, which we are hoping will be removed fairly soon. And there will be expectations on how we do things. And like I said at the start, for me, that's kind of the big soapbox issue is we've got to be able to demonstrate that we're doing things right to reduce transmission risks so we can keep doing what we're doing and be in, which we have to accept as a privileged position as being an essential service. That's not to say we're going to have a recipe book of you have to do this and you can't do that. We'll be expected to follow concepts and approaches. Not specific things. So I don't think we're going to get guidance from anybody that says you have to do X, Y, and Z. You have to use this disinfectants and do it this often. We're going to get bigger picture things that we have to address. So this is a document that was just released today. OVMA sent it out. I just put it on our website. And this is kind of a preparation for reopening. So reading the disclaimer is important. So this is an Ontario specific document. All the concepts are the same. So if you don't have restrictions on what you're doing, in other provinces, you could roll these ideas out. They aren't rocket science, and there are a lot of what we do, but there might be some things you haven't thought about. So this is, for Ontario, this is preparation for the phase when urgent is removed. This isn't saying urgent is removed yet. This is saying let's be ready, because we want to be able to hit the ground running and do things effectively, efficiently, and right once we get restrictions removed. General concepts. So like I said, we're looking at kind of high-level expectations as opposed to specific detail. So the way this document is framed is we've got, these are the main areas that we need to address, and we need to be able to explain to someone. If public health came in or a reporter came in, here are the main areas that we're covering. And then the details of how you do it's going to vary practice to practice, but these are all the things that we need to think about. So we go over in that document kind of examples of these. So physical distancing, how do you do that in a clinic? How do you do that in the mobile practice? How do you do that in the ambulatory practice on a farm? And details there with various tips. And like I said, some of this is taking things from grocery stores, but we need to think about a whole range beyond curbside delivery. Like curbside delivery is good. We need to keep people out of the clinics as much as possible, but ultimately they're going to get back in at some point. So we still want to do as much curbside action as we can, keep fewer people in, but you need to be thinking about your waiting room. So what should be the capacity of your waiting room in terms of occupancy? How do you reduce that? How do you move chairs around so people aren't sitting close together? How do you protect your receptionist? Do you put in plexiglass shields like they do in most retail places now to protect them from aerosols? Do we have lines on the ground that show where people should stand when they're in line? How do we move people through the clinic so that we don't cross paths? And that's distancing of clinicians. So how do we function in the back end of the clinic so that we stay apart as much as possible? And what do we do when we're together? And how do we prevent mixing? Because the whole concept here of social distancing is reducing human-human interactions. So that's reducing the number of interactions and then reducing the duration and closeness of those interactions. And there are a lot of things that we can potentially do there. So in terms of the big picture stuff that we need to think about, physical distancing, Alternate service delivery, telemedicine is kind of the lead there. And, telemedicine isn't something we're going to do right now and then drop completely. There certainly is a story to be made for maintaining telemedicine as a replacement or as a complement. And it could be telemedicine as part of the appointment, and then they come in for a shorter animal visit within the next couple of days or to get their vaccine. So we can keep fewer people in the clinics, keep them in for a shorter period of time, and potentially do some of that telemedicine by people outside of the clinic. So if we have, if a clinician is doing telemedicine that day, they don't need to be in the clinic. So it just drops your critical mass by 1. Self-monitoring will be an important thing persistently, is how do we make sure we don't get sick people in the clinic? Certainly we have a number of clinics in Ontario that are closed right now because they've had COVID spread amongst the staff. And we can't absolutely prevent that, but we want to reduce that as much as possible. Personal protective equipment, kind of similar things we've done before, but what do we do over the long term? So as we start thinking about cloth masks for routine use. Cleaning and disinfection is pretty straightforward. Thinking about response to an infected employee, how we support public health and do that, and how we try to make it such that if we get a positive employee, the implications for our practice will be as little as possible. And there are various things we can do, like cohorting, try to reduce the number of people that have been exposed. And what I often say is, a good exercise is pick some person at random in the clinic and pretend they got exposed. Could you, with any degree of confidence, explain to public health that some other people in your clinic were not exposed, so they don't need to be self-isolated? Or is everyone screwed, right? If one person's affected, you're all mixing together. That one person gets infected and sent home, and all its contacts are similarly self-isolated. Are you shut down? We can't always do that, right? Depends on your practice design, practice numbers, but there are some things we can do to reduce that risk. And there's general infection prevention and control. It's the good old basic boring infection control things that we need to do that will be really the framework of everything. Why is it not business as usual? Well, I guess I explained that at the start. We've got this ongoing risk. We have a very small percentage of protected population. Case numbers are going to go up, and we need to be able to protect the population, and we need to be able to demonstrate that we're able to function as an essential service with no restrictions on what those services are, with minimal impacts on the epidemiology of this disease. And being proactive. For me, the more proactive we can be, the more we can say, we're good, leave us alone. Go worry about other retail sectors, other industries. Veterinary medicine is on the ball. We know what we're doing. I'll pause for questions in a second. So one thing is this is just maybe a bit of a curiosity or fun thing for me. If you have ideas are great. So we've got that document we just released. I'm hoping that we'll be able to update it over time as we come up with new ideas. We'll see how things work and what doesn't work. The other thing I'd like to see, again, is that, demonstration that we're taking the lead. So if you have ideas, if you have pictures, what you're doing in your clinic you think is interesting, feel free to send them off. I'd love to be able to get a series of pictures we start putting up on the blog, and we send them out through Instagram. And here's responsible veterinary medicine in a COVID era. Here's something that we're doing. Here's a tip. Well, maybe it just shows the public that we're doing things, again, controlling that news cycle. But also maybe it's something that another practice could look at and say, hey, that's easy. We could do that. We hadn't really thought of it. So if you're interested in doing this, feel free to send me anecdotes. Feel free to send me pictures. If you send me a picture, let me know if we could post it somewhere. I think, again, we're trying to take the lead and show that we get as much discussion as we can to make things the most practical and most effective, but also to demonstrate to everyone that we're taking this seriously and we're in control. So actually, I'll pause for some questions here now. So we've got here. Have you heard of house call practices in the country doing backyard calls to maintain social distancing with owners? Oh, absolutely. And that's part, we've got some information on mobile practices. I did a post on our blog a while ago, and in the OVMA document, there's a section on social distancing for mobile practices. Yeah, mobile practices are inherently higher risk because usually there's an owner more intimately involved in the appointment. But there are things that we can do. And part of that is thinking about the risk status of people in the household. So if everyone's healthy, great. If you've got someone that's got respiratory disease of unknown source, let's keep them away. If you've got someone that's got COVID, let's really keep them away. But if you've got a household that's infected, well, this person recovered, they're going to be very low risk now. So let's find the recovered person or the clinically normal person and try to figure out the best way to create that situation, minimize the amount of time we have to have contact, make our procedures most efficient, and then do them in lower risk areas. With my sampling, I do it in garages as much as we can because it's outside of the house area. So I go into they pop the door, I go into the garage, get garbed up, they come out with the animal, we do our sampling, they leave, I leave. It's a very easy thing. The one thing I just, and people that do mobile practice will be aware of this, is animal restraint, right? What you don't want to do is be chasing the cat down the road because it got out. So a dog in a backyard that's fenced on a leash is a little different than a cat that's on a table, picnic table in the backyard. But the more we can do to remove ourselves from high-risk people and high-risk situations, absolutely. That's where some of the creativity has to come in. Any suggestions on what to wipe animals' fur down? Is this necessary? Yeah, this is the ongoing question, right? So can animals get their hair coat contaminated with this virus? Well, absolutely, right. If I'm infected and I cough on my cat or I touch my face and I touch my cat, I put virus there. How long does it survive is a question, and we have no idea, right? This is an envelope virus. It can survive up to a couple days on some surfaces, but no one's tested our animals' hair coats as a surface. So we should go in with some assumption there's a duration of survival that's maybe hours, maybe it's minutes, maybe it's hours, it's probably not days. And it's most relevant for us. Like in the household, we certainly don't want people wiping the animals down because they're just in that constant exposure environment. Where it's relevant would be when the animals leave and go to a different risk status area. So they come from a positive household where the owner has just been all over that animal, and then we're wrestling with that animal a few minutes later. That's when we need to think, we don't know what the risk is. The risk is probably low, it's not zero. So is wiping down something to consider? And I think it's perfectly reasonable to do, wiping down the common hand contact sites if we can do it safely in the context of patient care. What to use? We don't really, anything will kill this virus. You know, a bath would be highly effective. A bath requires a lot more handling. We can't bathe all our patients if they're sick. Disinfectant cloths. So if you think about disinfectant cloths, the safety issue there is really low because if I've got an accelerated hydrogen peroxide wipe, for example, I'm touching it with my bare hands when I'm wiping things down. So if I touch the animal's hair coat, I can't see any plausible concern. Actually, the accelerated hydrogen peroxide is used as a shampoo, as a topical therapy. I think we want to know what you're using. I'd be wary of people using bleach unless you knew the concentrations. We can use very dilute concentrations of bleach for bathing. It's used in people for some things, but bleach has more of a margin, more of a risk of dilutional error. So I think any routine disinfectant done right as a wipe would be fine. Even just a damp cloth is going to help to some degree, or a soapy cloth, or chlorhexidine rinses, chlorhexidine mousses. Chlorhexidine is not a great disinfectant for this virus, but it'll still do something. So I think if you've got an animal coming from a high-risk household, it's not unreasonable to do at all. It's quick and it's easy, and I can't think of a contraindication. It's not something I would do for every animal, realizing that because of asymptomatic infections, we don't know all the time when the animal's coming from a high-risk household. And that's why we just try to balance practicality and protection. And that's why we do things like wash our hands routinely for the things that slip through. So we don't really have any more evidence at this point. It's kind of a hard area to investigate because we're not looking at doing viral culture on the hair coats of exposed animals. And then even if we find the virus, is it enough there to cause an infection in a person? So a lot of big questions there. A question about, should we be looking at clinic-specific testing programs? So we're looking at testing of staff. So this, testing is still the holy grail. If we test, we know what's going on because then we can isolate people a lot quicker and contain this. Testing's fraught with some issues. One right now is test availability, obviously. As that ramps up, that's going to be less of an issue. And, testing of healthcare workers, testing long-term care facility workers, that's becoming, fairly commonly accepted. And the reason it's done is because if they're infected, they're more likely to kill someone, right? We're not looking at testing very routinely everyone in every occupation. Now, there's some issues with testing. So testing, from a disease control standpoint, testing everyone that walked into the clinic every morning would be useful. All your staff, you could test them on the way in. You get into some practical aspects. So if you have to take the sample and you get the results back 3 or 4 days later, that, knowing that positive 3 or 4 days ago may not help you a whole lot from a clinic control standpoint. Sampling is a bit of an issue. So a good sample right now is a deep nasopharyngeal swab, which is pretty unpleasant if you talk to anyone that's had it done. People aren't going to subject to that commonly. If saliva testing, which has some promise, becomes a sensitive test in clinically normal people, and that's still an if, but if we can do rapid saliva testing, then that makes that sampling issue go away. If you can get patient side or clinic side testing, if you've got a snap test essentially, that you could test yourself on, all your staff on every morning with saliva, then it becomes more practical, depending on the cost. But then as a clinic manager owner, you need to think about a lot of other issues. You've got occupational health issues, you've got labor issues, you have privacy issues. If you mandate testing and the person's status in the clinic is dependent on them getting a test, especially if you know the results of that test, gets a bit dodgy. And God help you if you decide you want to fire someone and they had a recent positive, and you can get claimed that you're firing them because of their status. You've got occupational workman's comp issues. There's a whole range of things. So I'm not saying dismiss it completely, because I had this question, some comments that came up this morning. I was writing on a veterinary college administrator listserv. It's worth exploring it, thinking what your logistics would be, thinking how you would handle a testing, who would get the information, what your response would be. But I think it's very much developmental, because there are a whole range of issues. And I think for most practices, they might not want to go there. But we'll see where testing goes. Like if we've got a $2 spit into this thing test that tells you result in 2 minutes as you're walking in the door, and we can get by some of the social liability privacy issues, there might be a role there. Do I think travel restrictions for staff are necessary to protect teams? And I think it's reasonable. I think right now, I don't think you're going to see a lot of elective travel. So basically anything that makes this person at higher risk, puts risk for exposure, puts risk to that team. That could be travel. That could be they're not socially distancing at home. It could be having a sick person in the household. We have various gradations of risk. And I think this is going to be a really touchy topic when fall and winter hit. So as things start to drift back to maybe normal mentality, but we still have a lot of disease risk and people want to start traveling to the US. It's going to be tough. Like, are we going to mandate 14-day self-isolation? And a lot of it's going to come down to what happens in different places like the US. Because if we have things under control here, and they don't in Florida, going to Florida poses a significant risk probably. If we've got things equally controlled here and in Florida, and if someone's going to Florida and they're hanging out at the beach by themselves, then is that much of a risk beyond travel? So then brings in the question of how well is our airlines doing it, and what's the epidemiology there? Are we seeing transmission associated with air travel with changes in distancing? So I think it's way too early. I know I'm rambling a bit here. I think it's going to be something we're going to have to talk about once travel gets restricted. Do we do travel? Do we do restrictions? Do we get testing? Will testing be an option, right? We'll test not in the clinic, but maybe can people go to public health and get a test after they've returned from travel? Remembering that a single test is not going to be diagnostic. No test is 100% sensitive. And if I get tested today, maybe I'm incubating a negative, but I can be positive tomorrow. So testing is an assistant tool, but it's not a guarantee. So it's a great question. I think that's one that we could be discussing later on in the year when it really starts to come up. It's not really an issue now. This question about, or comment, no in Alberta, they're testing anyone with any sign now, whether in contact or not. And that's getting more common. As testing becomes available, we want to test more because we want to see if people are positive that don't have known contact. Because, if you just focus on the knowns, you completely miss that whole unknown transmission pathway that might be out there. And we know that a lot of people have asymptomatic infections. So, and that's where we're heading, I think, everywhere is testing anyone with consistent clinical signs. And then the next step would be testing people that are higher risk for exposure without clinical signs if you really don't want to figure out what's going on.
Two comments before that. Yeah, the question actually says, what do you do if your health unit refuses to test?
That's what I just going to, yeah. So what do you do if the health unit refuses to test a symptomatic or in contact person? There's not much you can do, really. You can discuss it with them is all you can do. Ultimately, if they won't test and there's suspicion, then they should be self-isolating. So, and as we're getting into flu season, right, if people have respiratory disease, it's easy just to say, okay, you've got your 14-day self-isolation period. Like perceived lack of need might be true perceived lack of need by a health unit. It might also be prioritizing if they've got limits in swabs, right? So testing capacity is an issue in some places, and that's based on lab issues, but it's also sometimes based on swab availability. So if your health unit doesn't have a lot of swabs, the lack of need might be more, we want to test people that are more convincingly infected or people that are going to, where a result is going to change something in what we do. So hopefully that's going to improve over time. All you can do is really talk to them and try to convince them that testing is valuable. But we'll see the messaging about changing testing a lot. Testing is ramping up. And if we can get effective, easy patient-side tests, then that'll be the game changer if the supplies come out with it. And that's still the problem now, is getting it effective. Some of these, some of these tests that got a lot of buzz is the 5-minute tests, the rapid tests, the Spartan Diagnostics test from Ottawa. They've been recalled based on various issues. Spartans was recalled based on concerns about the swabs. The machine in the US, they've got, what was it, a 15% false negative rate. So the technology is still in development. But ultimately, I think presumably will be a easy lateral flow test or something, hopefully in the not too distant future, which will make it a lot easier. If there are any
other questions from anyone?
That's this here. Oh, hang on. Any outbreaks, cases of transmission linked to a vet clinic from contact tracing between staff, between clients and staff? I don't know about between clients and staff. I know about between staff, absolutely, because I've dealt with multiple clinics that are closed because they've had multiple veterinarians or multiple personnel with COVID. Whether that came from a client or whether that came from alternate routes, I think the ones that I know the most about was a staff member that brought it in probably from a non-occupational exposure. So they got infected from somewhere in the community, but brought it into the clinic and then spread in the clinic, which is why we need to think about distancing within the clinic as well, right? We're distancing from owners, but we also need to distance from ourselves in the clinic, because all it takes is one person. You get one person that's infected in the clinic and you can infect everyone else. If it's the COVID positive employee, would you need to close the whole clinic and for how long? That's gonna be a public health call. And I think that's one of the reasons a lot of this work on social distancing in the back end of the clinic is really important, and thinking about cohorting, because if public health comes in, what I want to be able to say is, okay, here's who that person is exposed to, and here's who they weren't exposed to. And here's why I have confidence they weren't exposed. So ignore them, right? All the people that they've worked with, had close contact with, we can self-isolate them, but we've still got this core group of people on staff that weren't exposed, so they're fine. If public health can't be convinced that everyone wasn't exposed, they're gonna say everyone's exposed, and they're probably gonna say everyone go home for 14 days. So that's the reason why we want to do as much as we can behind. So we say, okay, this person was only in this area, they only work with these people, we all wear masks for any types of contact, here are all the things that we do. Do you think there's any real risk? Right? And that's the discussion that we have to try to convince them if we don't think there's a risk, so that we can maintain operations. So that would really depend on the situation. So the more we can document, the more we can do things better, the more likely we're going to avoid a full immediate closure. Should we mandate wearing masks at all times in the clinics? I think we touched on this one last time. It's not unreasonable, and it's important to remember what masks are for, right? So we got two different things that we are using PPE for. One is to protect from the user, and one is to protect the user. So when we're thinking about masks, N95 masks are to protect the user. So if you're doing an aerosol generating procedure with a potentially infected animal, or you're in a hospital, then you want an N95 mask to protect you from breathing in that virus, as long as you have eye protection as well to cover those mucous membranes. That's not something we're talking about for routine use. So when we're talking about using cloth masks or surgical masks, we're using those to reduce the risk from the user. So the reason this is important is because if I'm using an N95, I'm protecting myself. If I don't use it, I'm only putting myself at risk. It's like a seatbelt, right? If I don't wear a seatbelt, I'm dumb, but I'm putting myself at risk, no one else. If I go into a hospital and we're wearing masks, cloth masks, we're wearing that to protect everyone else. So if one person says, I'm not going to wear the mask, they're not impacting their health status. They're impacting the risk of others, because the mask is there to prevent me from infecting someone, not from me getting infected. It'll help me to a degree. It'll help filter out some stuff. It'll prevent me from touching my nose. But cloth masks or surgical masks in a clinic are to protect from the user, so everyone has to wear them. So if you're in a clinic and you've got people that are worried about it, or you're bringing in something to protect people when they have to breach that 6-foot barrier, then it really should be a mandatory thing to wear masks. And you can wear other things if you're worried about protecting yourself, such as eye protection, but the mask is a population control tool. Whether you should mandate wearing them, that really comes down to how the clinic operates, how much risk there is, how much risk aversion there is, how much time you spend in close contact. But anytime we breach that 6-foot barrier, we're creating a risk. And wearing a mask will reduce that risk. We don't know how much, cloth masks are variable, but it's certainly a reasonable consideration. It's not hard to do. You don't need to wear them all day, but we want to have them on when we're breaching that 6-foot barrier. I've read the latest recommendation is to use cloth masks in a hospital when situations not allow for, yeah, so that's basically what I was saying, yeah. So if we can't maintain, so we want to do everything we can do to stay away from people. And then when we're going to be together, we want to be efficient. So if you're going to put a catheter in this dog, I want everything laid out. I want all the stuff there. I want to know exactly what's going to happen so that we don't spend much time together, but someone's going to have to be close proximity to me because someone's holding a dog. So that's when wearing a mask, each of us wearing a mask is going to protect us from each other. If we're really worried, then you can add in a face shield or you can add an eye protection. And that's not unreasonable to add in a reusable face shield because it's not going through consumables. If you're going to get that close together and be breathing close to each other, you can put a face shield on for personal protection. But for protection of the others, that's when the mask would make a lot of sense. Did I talk about shielding at the reception desk? I did really briefly. I think it was the thing we need to consider, right? Just like in the grocery store, this is one of our long-term things is should we be putting plexiglass barriers up so that our receptionists are protected? Because right now, I think we're still focusing on curbside delivery. Over time, people are going to start coming into the clinic. We still want to keep that as little as possible through various measures like telemedicine, maintaining curbside and other types of drop-offs, but we will end to the point, presumably, when people are going to be in the clinic. And thinking about how many people are in waiting rooms, distancing them from staff and barriering them from staff is certainly something to think about. So again, this is why we're being prepared. If you've got a clinic, not a bad idea to start thinking about what you could do, thinking about sources, trying to figure out where you can get plexiglass, what's it going to cost, how are you going to get it installed, so you can be ready to go if you think it's something that's going to happen, as opposed to waiting until someone mandates it, then it's you and every other clinic or every other business in the area that are trying to sort it out. So it's one of these proactive things. It's also one of these things that people could share, right? If you find out and you want to share information on it, we're happy to help send it around. So I think it's definitely something to consider. It's one of a whole list of things we have in that document that we should be thinking about as we move forward. Should anyone in the surgical suites wear cloth masks or the regular surgical mask? So again, we're getting into thinking about what situations we're using a mask for. So for the operative procedure, we want people over the patient or over the surgical table wearing ideally a surgical mask. If you have enough surgical masks, that's when we want to use them. If you have someone that's in an operating room and they're not over the table or over the patient, they don't need to wear a mask. So if we look at I used the example the last time. So anesthesiologists in the UK often don't wear masks in human medicine. And it's perfectly fine. They're not over the table, they're not over the patient. You just don't have them yelling or coughing in close vicinity. So if you've got someone doing surgery, they should be wearing a surgical mask, an assistant wearing a surgical mask, someone that's monitoring anesthesia, someone that's popping in and out, giving supplies, they probably don't need a mask. In a situation where we're breaching that 6-foot barrier, though, that's where the cloth mask would come in. So cloth mask is kind of, if you think about what we could do in the pre-COVID era, just slap a cloth mask on them, right? So that's for our normal types of close contact. But we still want to maintain our higher levels of PPE for things like surgery if we can. If you're out of surgical masks, then a cloth mask is going to be a tolerable alternative. If you're running low of surgical masks, then I would prioritize them. So I would want to make sure I had a surgical mask for an orthopedic procedure, for example, over a spay, where I'd be more comfortable with a cloth mask. But I think anyone in the surgical seat, if you're getting with that 6-foot barrier, should have a mask of some sort. There should be a surgical mask if we're worried about the patient, the operative aspects. Otherwise, a cloth mask is okay. Where do you find decent cloth masks? Good question. I know you can buy them online. You can make them quite easily. CDC has a template. If you just Google CDC and mask, or if you email me, you can get it. And one is set of designs for ones that you sew. There's another one that's just for cutting. You have a t-shirt and you can cut out a pattern with a pair of scissors, you can make them. So there are various people. I know at OVC, there have been some volunteer sewers that produce a large number of masks for us. You may have clients that are good sewers. I've made up some masks myself. I'm not a great sewer, but I was able to do it. So it's not that hard to do. And I assume that we'll start to see cloth masks really readily available over the counter as everyone sees a long-term market for them. Is it acceptable at this point to be doing garden visits for vaccination or non-urgent care? So this is the question. The question here, I guess, is where are you? So if you're in Ontario, we're still under the urgent care directive. So you would have to be able to make the argument that it's urgent care. And that's case by case, right? There are situations where various things can be urgent that would not seemingly be so. But I think you need to be able to, my acid test basically is if the CBC Marketplace comes up to you and they're doing an investigative report on why vets are doing stuff and we can't get physiotherapy in people, can you make the 15-second soundbite argument that this animal needed it and needed it now and not in a few weeks? So if we're in Ontario, I think we're still trying to make sure we're just doing urgent care, because I think that'll help us get back to non-urgent care quicker, because we're saying we're good, right? We're being responsible. And my assumption is the urgent care directive will be removed fairly soon. If you're in a province where there's not an urgent care directive and everything's lumped under essential, then absolutely. And doing garden visits to reduce that risk for the household would make sense. But I think if we're under an urgent care directive, we still should be trying to be as good in compliance with that as we can, but it's all case by case.
And I think we're running out of time. We're a few minutes actually over. Any last minute or last comments, Dr. Weiss, before we wrap
No,
up?
I don't think so. Like I said, though, any questions, feel free to email me. If you have pictures or ideas on social distancing stuff, especially if you're willing to share it, just to get some more discussion, some more buzz about the profession, feel free to send those to me at that email address. If you've got ideas, what you'd like to talk about for the next one, that's always good. We're tentatively planning next week again. But yeah, whatever questions you have, it's good to know so we can address that, whether it's through information materials or through blog posts or through another town hall.
Perfect. And we will be having another town hall scheduled at the same time next week. The recording will be available on our website. Lori will work actively to get it up as soon as it's available. If you have any other questions, please feel free to contact us, and we look forward to seeing you next week. And thank you again to Hills Pet Nutrition for sponsoring this series. Have a great day, everyone.
Great. Thanks, everyone.